So I'm very pleased to be here today to report on these findings from the VA Care Coordination Query. I would like to acknowledge the funding that we received from the VA Query program, as well as my co-authors at the VA, Greater VA in Los Angeles and South Texas Veterans Healthcare System, and I have nothing to disclose. So healthcare is extremely complex. Even within an integrated healthcare system like the VA, care coordination can be challenging. In response, the VA and other healthcare systems have adopted the patient-centered medical home as a service delivery model to improve quality and care coordination, and also to provide team-based, patient-centered, longitudinal care. Despite modest improvements in quality, gaps in communication and care coordination have persisted. Not surprisingly, care coordination can be doubly challenging for veterans who navigate two or more systems of care. Dual care in the VA can occur when veterans are enrolled, for example, as Medicare beneficiaries or live in communities with geographical barriers to health care. Unfortunately, dual care has been associated with care fragmentation, duplication of services, and other gaps in quality. The Mission Act of 2018, which aims to increase veterans' access to community care when they are not able to access VA health care in a timely manner, aims to increase, has raised concerns about increased demands for care coordination and requirements within the VA. In order to explore these care coordination challenges, under community access standards that were in place prior to the implementation of the Mission Act, we compared healthcare system hassles or problems experienced by veterans who receive health care from VA providers only versus those who receive dual care from both VA and non-VA providers in the community. For this analysis, we used baseline data from the Coordination Toolkit and Coaching Project, which was designed to improve veterans' experience of care coordination in primary care. We recruited and cluster randomized matched pairs of VA clinics that shared similar panel sizes, the number of primary care teams, and types of outpatient services that were offered. 6 matched pairs of clinics from 4 geographically diverse states agreed to participate. Using the corporate data warehouse, we randomly selected patients with 4 or more primary care visits to their assigned clinic during the prior 12 months. At 10 of the 12 participating clinics, we selected 480 veterans each. And at the 2 remaining clinics, which were relatively smaller and provided comprehensive women's health services, we selected all of their patients. And this yielded a total sample of approximately 5,100 patients. We collected patient surveys prior to the start of clinic intervention activities, and we mailed survey packets that included a letter of invitation, a printed copy of the survey, and pre-addressed, prepaid return business reply envelopes, as well as optional instructions for taking the survey online or by telephone. Our dependent variable was measured with the healthcare system's hassle scale. This 18-item patient experience questionnaire, which was developed in the VA, is recognized by the Agency for Healthcare Research and Quality as a measure of care coordination. It assesses problems with general health care, especially those that might be experienced by patients with multimorbidity or with complex medical conditions, such as poor communication between different healthcare providers. The Hassel Scales instructs the respondents to rate how problematic each of the listed items are using a 5-point scale ranging from 0, not a problem at all, to 4, a very big problem. For ease of interpretation, we dichotomize the ratings, yielding a total hassles count ranging from 0 to 16 hassles. We imputed missing values if the veterans completed 80% or more of the items on the questionnaire. We also included an item for the veterans to indicate whether or not they had received VA care only or dual care during the prior 12 months. We also asked them to rate their physical and mental health status using items adopted from the SF-36. And we also collected basic demographic information. Over 2,400 veterans returned surveys with eligible responses. The veterans were predominantly male, 65 years of age or older, and majority were non-Hispanic white. A slight majority indicated that they had used dual care in the prior 12 months. The number of reported hassles ranged from 0 to 16, and 79% reported experiencing one or more hassles. The top 5 hassles reported by the veterans were having to wait a long time to get specialty appointments, poor communication between different providers, lack of information about treatment options, as well as lack of information, basic information about their medical conditions, as well as difficulty getting questions answered or getting medical advice between scheduled appointments. For 15 of the 16 hassles items, significantly higher proportions of dual care users reported problems than users of VA care only. For our multivariate analysis, we used zero-inflated negative binomial regression, which simultaneously estimates separate logit and count regression models. We examined the number of self-reported hassles comparing veterans who received VA care only versus dual care, and we adjusted for self-rated health, sociodemographic characteristics, and clustering of veterans within clinics. We also calculated predictive margins and associated confidence intervals to estimate the predicted number of hassles experienced. Our logit results indicated that veterans who reported being dual care users or were less than 65 years of age or who rated their physical or mental health as fair or poor experienced significantly less, were significantly less likely to report zero hassles or no problems. In contrast, veterans who had not graduated from high school were significantly more likely to report zero hassles or no problems. The count results indicated that dual care was independently associated with higher counts of self-reported hassles, with an adjusted incident rate ratio of 1.15. In addition, age less than 65, Hispanic ethnicity or Asian race, and physical or mental health rated fair or poor were independently associated with significantly higher counts of self-reported hassles. And finally, dual care users are reported experiencing more hassles than VA-only users with an adjusted predicted average of 5.5 hassles versus 4.3 hassles. So in summary, we found that veterans who used dual care reported significantly more challenges than veterans who used VA care only, experiencing on average 1.2 more hassles. In spite of the relatively large sample of veterans who were randomly selected from diverse clinics, our findings should be interpreted with caution. And that's because the participating clinics were not necessarily representative of VA clinics nationwide. our response rate was relatively low, although it was comparable to response rates of other uncompensated surveys. We were unable to determine whether or not the non-VA care was paid for by the VA, and we did not assess factors that may have been associated with the use of non-VA care, such as geographical barriers. Our findings, however, suggest that the VA may want to explore new strategies to help optimize care coordination for dual care users that are expected to increase given the 2018 Mission Act. The VA Care Coordination Query is testing some of these strategies through initiatives such as the Coordination Toolkit and Coaching Project, which is a quality improvement initiative that is comparing the effectiveness of an online toolkit alone versus the toolkit plus distance coaching to help primary care teams improve their care coordination strategies. The Hassel Scale is the primary outcome for this project. Data collection for the follow-up surveys is in progress, and it's expected to be completed by early 2020, and we're looking forward to analyzing the findings.